This video is to go through the images that we were not able to last week because of the weather. And so the first couple of questions dealt with looking at and appreciating the normal look of the heart. Recall that when we drew the normal look of the heart, we would have a round and concentric left ventricle and a crescenteric right ventricle that kind of hung out next to the side. Please also take this opportunity to redraw the physiological view of the heart, which almost looks like a window pane. Recall that if we separated the chambers, it is input from the body which goes to the right side of the heart, which then drives blood flow to the lungs and then subsequently the left side of the heart. The reason why we care about that is that when we have failure of the left side, we'll have that backwards kind of back pressure and backwards failure towards the right hand side, which helps us explain why the number one cause of right-sided heart failure is going to be left-sided heart failure. So please take this opportunity to review normal blood flow through the heart. What we're seeing here is a typical case of a left ventricular hypertrophy. So this slide is going to be left ventricular hypertrophy. And you can tell by the overall increase in thickness of this left ventricle. It's just absolutely massive. And you can tell that this is most likely going to be due to hypertension, systemic hypertension, which has occurred over a long period of time. You can see and appreciate how the chamber of the left ventricle has decreased in size, whereas the myocardial thickness has increased dramatically. Also, take a look at how we can see a branch of the coronary vessels and look at the distance by which blood has to travel to perfuse this entire muscle. Again, we had said that this is hypertension driven. We can also say that an individual who has aortic stenosis can also have that pressure overload. This is going to be due to pressure overload, which is going to drive concentric hypertrophy. We'll notice that in the next slide, we can look at the typical histologic findings that are going to be found with a myocardial hypertrophy. On the left-hand side of the image right here, if we look at the left-hand side of the image, this is a normal size of myocardia. The tiny little darker circles are going to be the nuclei, whereas when we go to the right-hand side of the screen, and I'm circling some of these guys, these have a very characteristic name. The nuclei enlarge in cardiac hypertrophy because we are sending signals to make brand new sarcomeres, so we have this increased expression of protein production. And so these are called boxcar nuclei. So what you're looking at here are called boxcar nuclei. And again, this is a telltale sign that the individual has hypertrophy of some sort. The slide that we're looking at right here is demonstrating the two different types of hypertrophy. If we look right here, we have a normal heart. Concentric hypertrophy is going to be here, and then eccentric hypertrophy is being shown right here. Remember, this is going to be anything which is going to increase pressure. Here, it's going to be volume for eccentric. And notice that we have a couple of concentric versus eccentric etiologies. Remember, for pressure overload, we will have things like hypertension. We can have valvular disorders, so we can put aortic stenosis. Notice that it isn't always going to be on the left-hand side, so we can sometimes have things like pulmonary stenosis, which can also cause concentric hypertrophy, but on the right-hand side of the heart, as well as the fact that we can have certain type of congenital disorders like cardiomyopathy. So I'm going to put cardiomyopathy here, even though we haven't talked about it in great detail. For eccentric etiologies, volume overload, you could have regurgitant valves. So you can have aortic regurgitation as a possibility. You can have pulmonary regurgitation. You will have shunting diseases, so shunts. Specifically, when that blood shunts from one chamber to the next, that chamber in which is going to have the increased volume will dilate. And you're going to notice that I'm also going to place cardiomyopathy here as well, because cardiomyopathy is not simply one disease, but a multitude of diseases. In some cases, the cardiomyopathy causes a concentric hypertrophy. In other, it will cause an eccentric hypertrophy, and we'll get to that this week. What we're looking at here is one of the consequences of right ventricular failure. And right ventricular failure is going to have several different signs. The sign that we see here is an increased jugular venous pressure. Again, remember, if I draw a line from the jugular notch and then put a ruler here and then measure how visible I can see this jugular vein, normally it should not go beyond 4 centimeters. And so if we ever provide you with an example of increased jugular venous pressure, I will place it at the upper limit. I will say that 5 or 6 centimeters of this is going to be visible. Therefore, you really know that they have this dilated neck vein. I'm not going to make it 1 or 2 centimeters and make the expectation that you think that it's going to be right ventricular failure. There are other things that you're going to find with right ventricular failure. In addition to increased jugular venous pressure, the individual will have nutmeg liver, which we can see. We will see hepato and splenomegaly. So these guys are going to increase. The individual will have ascites. Remember, we're going to be driving a lot of plasma from capillaries into spaces. We can also have that hepato-abdominal jugular venous reflex. So if we apply pressure to the right upper quadrant, the individual's neck veins will dilate as well. And again, these are all signs of right ventricular failure. The one thing that I'm demonstrating right here is pitting edema. And pitting edema in a right-sided heart failure will be bilateral, even though we're looking at the right lower extremity here. Now, pitting edema is going to have two major ways by which we can assess its severity. One is the actual depth of the pit, and the other is the time at which it takes for the pit to resolve. In terms of this slide here, we're showing you how we assess the depth in terms of severity. And you'll notice that in a clinical case narrative, we can talk about a patient having a 1+ pitting edema, or a 3+ pitting edema, or a 4+ pitting edema. These pluses are basically telling us the depth at which the pit is going to exist. So you'll notice that a 1+ pitting edema will have a deflection of around 2 millimeters. And so if I put a ruler across here and then measure the depth of this, a 1+ pitting edema would have a 2 millimeter depth. A 2+ would have a 4 millimeter depth. A 3+ would have a 6 millimeter depth, and so on and so forth. The next slide is going to show you a congenital defect of the heart, and the congenital defect that we are showing right here is readily evident if you look at some of the other features of the heart. Notice how we see these trabeculae carnae, and the trabeculae carnae is a telltale sign that we are looking inside of the ventricles, so I'm outlining some of them. You'll notice that we're in a chamber right here, and you're going to notice that there's a chamber here as well, and the opening that we have here is inside of the ventricular septum. And so we are looking at a ventricular septal defect right here. That's a ventricular septal defect. Now, what are some of the clinical features in a ventricular septal defect? Well, one of the things that I want you to realize here, again, if we draw the physiological view of the heart, that window pane, and I'm drawing in the ventricular septal defect, blood is going to shunt from one side of the heart to the next, and so you're going to get a little bit of a volume overload here. However, that blood has to eventually go outside of the aorta, so you're going to have an increase in contractility on the left-hand side too. So you're going to have a little bit of cardiac hypertrophy occurring. Each time the heart beats, it's going to cause a turbulence of that blood flow going from one chamber to the next. And as a result, the individual will have what is called a systolic murmur. Recall that in heart sounds going from S1 to S2, this is going to be the closure of the AV valves, the S1 sound. The S2 sound is going to be the aortic and pulmonary valve. And so somewhere between the aortic and pulmonary, the atrioventricular valves closing and blood being ejected from the heart, you're going to hear this little swooshing sound. And so we call that a systolic murmur. Sometimes you'll read them as being called a hollow systolic murmur. Again, this is going to occur while the heart is actively contracting. You'll also notice that turbulence in the heart can sometimes damage that area where the turbulence occurs, and as a result, this area is prone to damage and inflammation. And so, depending on the size of this opening, it can go from being completely asymptomatic and the individual is unaware that they have this condition to having damage in the area of this turbulence and then producing the signs and symptoms of endocarditis. When we have endocarditis, we can develop tiny little clots in these areas which can break off and then travel distally. So we can go from being asymptomatic to having a murmur, all the way to endocarditis, which can throw thromboemboli and be potentially catastrophic. So all of these signs and symptoms exist on a continuum. Image 9, if we take a look at this for a moment, you're going to be able to see that the individual's thumb is pressing up on the atrioventricular valves. But notice we don't see any trabeculae carnae. We see a little bit of pectinate muscle here, which is telling us we're looking at the right atrium. And so we're looking at an opening here in the right atrium. So this is an atrial septal defect. What you're looking at here is an atrial septal defect. And we have a couple of terms here called Eisenmenger's complex versus Lutenbacher syndrome. If we look back at our lecture notes, an Eisenmenger's complex is just an alternate terminology for what we were talking about before in terms of how shunting diseases sometimes cause late reversal of the shunt. So normal shunting diseases tend to take us from a left side shunt to a right side. However, as an individual develops these compensatory changes of the heart, what will happen is that the right side of the heart becomes stronger and it begins to increase its cardiac output, and so we start to shunt blood from the right side to the left, causing a cyanosing. And so Eisenmenger's complex is going to be that particular late reversal of a shunt causing cyanosis. I want you to compare that to Lutenbacher syndrome, in which if, once again, we look at this physiological view of the heart, and I'm going to put the atrial septal defect here, and then let us suppose that the individual develops a condition where they develop mitral valve stenosis. And so we talked about this in a previous video. The mitral valve, due to whatever reason, and the most common reason is going to be things like chronic rheumatic fever, begins to close down. Now imagine if we have this atrial septal defect. Blood that enters into the left atrium is going to have a higher propensity of going into the right atrium. And that's what a Lutenbacher syndrome is this shunting of blood from the left atrium to the right atrium because of atrial septal defect plus mitral stenosis. This increases workload to the right side of the heart and increases the chances of the individual developing right-sided heart failure. So that's why we talk about Lutenbacher syndrome. The next slide, what I want you to do is I want you to concentrate on the great vessels which are exiting from the heart here and the great vessels exiting from the heart here. And so if we have the aorta here and we have the pulmonary trunk right here, notice we have this abnormal communication between the two. This abnormal communication between the two is called a patent ductus arteriosus. And a patent ductus arteriosus, again, is a left to right hand side shunt. The thing is it's going to give a very characteristic murmur, and they call it a machine-like murmur. And so I want you to attach that particular terminology with this congenital heart defect. It literally sounds like you're placing a stethoscope on a washing machine. And so that is the abnormal communication that is being described here. Image 11 is going to be a form of aortic stenosis. So we're looking at aortic stenosis here. And recall that there are a couple of different types of aortic stenosis out there. What we're looking at here is a congenital aortic stenosis in which we have a bicuspid aortic valve. Now, please realize and appreciate that aortic stenosis doesn't necessarily have to be congenital as it is in this case. In many cases, we will have what is called a senile aortic stenosis, and recall that a senile aortic stenosis is usually going to be due to the fact that we have atherosclerosis affecting each of the three semilunar cusps, leading to a decrease in the luminal opening here, making the left side of the heart having to pump with increased contractility to eject that blood. Same kind of thing happens in a congenital aortic stenosis because the lateral sides of the commissures of this new bicuspid valve tend to be fused, which decrease the available amount of blood which can be ejected from the heart. Again, left side of the heart has to work a lot harder, and as a result, you'll have some left ventricular hypertrophy. We had also said in a previous video that another cause of aortic stenosis is going to be due to a rheumatic fever or rheumatic heart disease. And in this particular case, the individual's immune system begins to attack the aortic valve. As a result, is going to lay down this fibrous connective tissue. We can subdivide all of these different types of aortic stenoses in terms of the geography. And we had said that some aortic stenosis is supravalvular. So for example, a supravalvular aortic stenosis would be a coarctation of the aorta. A valvular aortic stenosis are the three that we're talking about here. So congenital, senile, and rheumatic. And another one would be a subvalvular aortic stenosis, which would be due to, let's say, a cardiomyopathy, a hypertrophic cardiomyopathy. We'll talk about that in class this week. The major clinical features of this is going to be that the individual is going to present with what is called an ejection murmur. So ejection murmur. Because the opening is narrowed here and the heart has to work with greater contractility to eject the blood, you're going to get a lot of turbulent blood flow exiting from this valve. As a result, you will have, again, a systolic murmur between S1 and S2, specifically over the valve affected. So they will call it an aortic ejection murmur. And you'll hear this kind of really loud noise between S1 and S2. Again, since the left side of the heart has to work a lot harder, the individual is going to have left ventricular hypertrophy, and as a result, over a prolonged period of time of having left ventricular hypertrophy, the individual is at an increased risk of having failure as well. Image 12 is developing our understanding of mitral valve prolapse. In this particular case, the mitral valve is right here. Right here, we see the tricuspid valve. And notice the contours of the tricuspid valve. It has this kind of gnarled or almost corrugated appearance, and that's normal. Look at how you have this pillowy kind of billowing out of the valves here. They're almost blowing through back into the atria. And individuals who have mitral valve prolapse tend to have a familial distribution. We don't have a clear-cut etiology as to why most of the people develop this. However, individuals with Marfan's syndrome, osteogenesis imperfecta, Ehlers-Danlos syndrome, where they have a collagen defect, tend to have very, very stretchy papillary muscles and chordae tendineae, which allow the mitral valves to blow back into the atria. These individuals are going to have what is called a mid-systolic click, and that is a very characteristic sound in terms of oscillatory findings. What ends up happening is that the mitral valves, they will close normally, right? So we're showing the two mitral valves closing normally, but as the left side of the heart continues to contract, the one mitral valve blows kind of into the atrium. And this kind of blowing through causes a snapping or a clicking sound as it snaps over the other leaflet. You'll notice that individuals who go to a dentist have to tell the dentist of their mitral valve prolapse because sitting in an inverted position accentuates that click. And that click is actually the physical slapping of the mitral valve together. As a result, these areas are going to be especially prone to endocarditis. Anytime you hear a murmur, anytime you hear turbulent flow through the heart, I want you to tack on the possibility of developing endocarditis because turbulent flow can activate endothelial cells and cause them to become more sticky, providing the opportunity for things like fibrin, platelets, and even bacteria to stick to those valves. The image that you're looking at here is going to be called tetralogy of Fallot. So this is tetralogy of Fallot. Tetralogy of Fallot is going to have 4 unique attributes. The first attribute here is going to be pulmonary stenosis. So I'm going to show you pulmonary stenosis. As a result of pulmonary stenosis, the individual's right side of their heart, the right side of their heart is going to hypertrophy. So you're going to have right-sided hypertrophy. Now, the interesting notion in a tetralogy of Fallot is notice how the interventricular septum is going to be incomplete here. And as a result, the person has a ventricular septal defect. There we have it, ventricular septal defect right there. You'll notice that blood that is going to be within the left ventricle is then going to have a propensity for being ejected into the left ventricle. And so tetralogy of Fallot is that one example that we're telling you in class is going to be a right to left shunt. It is the right to left shunt that we will test you on. Notice I'm missing one thing. I'm going to tell you it right now. The fourth thing that you have in a tetralogy of Fallot is called an overriding aorta or dextroposition of the aorta. The aorta tends to be right on top of that ventricular septal defect, and so we find that in tetralogy of Fallot. This particular disease is going to be cyanotic right from the get-go. So a baby born with this is going to be cyanotic. As a result of that right ventricular hypertrophy that you will see, you have a characteristic heart shadow that occurs here. Notice how the left side of the heart almost appears as though it's projected this way. But what I really want you to concentrate on here is this prominent right side of the heart shadow. And a radiologist somewhere said that this kind of looks like a boot. So the characteristic radiographic feature that we see here is a boot-shaped heart. And so that is characteristic for tetralogy of Fallot. You'll notice that we will provide you with other radiographic images as the trimester unwinds to demonstrate cardiac tamponade versus left ventricular hypertrophy. All of these are going to be indications for cardiomegaly, which we'll get to next week. Image 15 is going to look really similar to another image, but what I want you to concentrate on here is not the fact that they have, again, this patent ductus arteriosus, but rather I want you to take a look at the aorta, all right? I'm going to trace the aorta here, and then I'm going to trace the aorta here as well. And notice how the diameter of the aorta right here begins to become more narrow. In fact, what we're looking at here is coarctation of the aorta. And we can see this on fluoroscopy. Notice how the diameter is much smaller here as it is here and here. And recall from class that in a coarctation of the aorta, blood pressure, which is going to be prior to the coarctation, is going to be increased. So the individual is going to be predisposed to nosebleeds, headaches, bursting of an aneurysm if they have them, but the lower extremity is going to have hypotension. If we have some of the intercostal arteries being given off here in the more proximal region, we'll have that characteristic rib notching that should occur as well.